get to talk about this is one of my favorite topics, and I think for a surgical pathology group, you may be wondering, where am I going to go with this? But the hopes for this talk are perhaps 2 or 3 things. One is that we talk about easy lesions and the interpretation of immunos in that setting that sometimes gets us in trouble. I want to raise awareness about more difficult lesions, and it's okay to ask for help in those. I think some things are very complex today. And overall, I hope that you walk away with new skills and tricks that you can apply in your practice. So I'm going to get started. I don't have anything relevant to disclose. The first outline is going to walk you through 3 sets of things that we're going to be discussing today. The first one is benign tumors. And I think it's a very common differential that we come across in clinical practice. The second one is atypical hepatocellular neoplasms and the spectrum, and when it's okay to call it hepatocellular carcinoma. And lastly, some specific variants of hepatocellular carcinoma that I find challenging sometimes to diagnose and new entities. Case number 1 is going to show you a lesion that actually has. Here we can see the carré, so that's the margin. The lesion is well demarcated. So we know that we are there, and perhaps I should have shown here that it has a slight nodular architecture. There's a pretty thick vessel here and a little bit of bile ductular reaction. These are all key features of this entity, and I'm going to show you the cytology a little closer, which shows pretty bland hepatocytes in an intact trabecular arrangement. Remember that the normal is 1 to 2 cells. So no atypia, no mitosis, looks hepatocellular, looks benign, well circumscribed. You may be wondering, what is the diagnosis? And I'm going to walk out for a second here. Let's back up and think about this more broadly. This is how I teach our residents, but I think it's a helpful framework to think about. There are things that happen in cirrhotic liver that do not happen typically in non-cirrhotic liver. So having this framework is helpful. I highlighted metastasis because metastasis can happen in both, but obviously non-cirrhotic liver are more common. Benign lesions, there's a significant overlap. FNH and hemangiomas can happen in both, but we don't diagnose typically hepatocellular adenomas in cirrhotic liver. And obviously, these plastic nodules are associated with cirrhosis. So having this framework, sometimes things help us think of what is the differential diagnosis and what are the things that I need to consider. And here is.
So what I want to talk to you about today is prostate core biopsies, essentially grading of prostate cores. But although we're going to talk about details, what I really want to discuss and put forth to you is the practical approach, a common sense approach on how you approach your prostate cores. And of course, we'll get into that in more detail. So the objectives today are to apply the latest guidelines in histological grading of prostate cancer, to understand the clinical significance and implications of what you're calling in your prostate cores, including those with intraductal lesions, and to understand when and how to utilize immunostains to aid in prostate cancer diagnoses. Things we do all the time, but I really, again, want to take it from this practical approach. So, of course, you all know prostate cancer is a really common disease and affects up to 1/3 of all men, especially older men, and represents about 11% of all cancer deaths. The thing is, though, as you know, we can detect these at much lower levels based on screening, and the good news is we find the majority of our cases at low-grade, low-volume cancers, but there's still approximately 12% of patients that will succumb to their prostate cancer. So really what I want to focus on, though, a lot is what about this other 88%? Those not with the high-grade tumors all the time, and those that we can actually do good for and hopefully cure, or even just watch and never treat. So that other 88%. And we can do this because of early detection, the low-grade indolence of what we see in localized prostate cancers, and the fact that we have adequate treatment for a lot of these tumor types. Of course, the other issue is that, again, as this is a disease of older men, that often as they're being watched or followed with low-grade disease that they may die of other diseases. But it's our job as the pathologist to stratify these patients into those tumor types that are low-grade and can be watched, or those that need to be treated more aggressively. So I'm not going to go over this in detail, but just generally speaking, when I think about prostate cancer, I think about it like any other organ system. We have well-differentiated tumors, we have moderately differentiated tumors, and we have poorly differentiated tumors. Despite all of these risk categories and all of these Gleason scores that we give all the time, think about it practically with common sense as well-diff, moderate diff, poor diff cancers. So with these low-grade cancers, we can put patients into active surveillance, which is something that we can do, not treat them surgically, decrease morbidity in these low-risk patients. Some are just in watchful waiting if they have a life expectancy of less than 10 years. It's important to understand what the criteria is for active surveillance, and this has changed a little bit over the last two decades, but specifically speaking, if we're going by sort of textbook guidelines, if you have a grade group 1 or a Gleason's 3 + 3 = 6 cancer, so low grade, low volume cancers in fewer than a third of the cohorts and with less than 50% volume.
So since it's Saturday, I guess it's late morning, early afternoon-ish, I decided to do something a little bit different, and we're just going to look at some scan slides together. Does that sound good? Yeah. The only caveat is that I would like some audience participation. Is that okay? Can we do that? All right. Okay. All right. So I have a hodgepodge of scanned virtual slides. I have papillary lesions and then a few examples of the triple negatives that we talked about. So I get the sense that probably the papillary lesions would be the highest yield to go through first. So we'll do that and then wrap up with the triple negative lesions and some salivary gland type breast cancers. And we'll try and keep this to like 50 minutes. Does that sound good? Yeah. Okay, cool. All right. So start from the very beginning, papillary lesions. All right, so this is a corneal biopsy, I think, chunky one. So you have fragments of breast tissue, very fatty breast tissue, and then this proliferation here. All right, so we have some sclerosis. So this is on low power, which, independent of this stuff here. This, stromal sclerosis with potentially some elastosis over here should make you worry that we're dealing with some sort of a sclerosing lesion, either a radial scar, complex sclerosing lesion, or a intraductal papilloma with sclerosis and adenosis. Then you come over here and you have this proliferation that demonstrates some kind of fibrous fibrovascular cores lined by cells that are, somewhat elongated, but not super stratified, where we had, in the other examples that yesterday we demonstrated with, cytologic atypia, where you have nuclei, at different sides of the cells. Most of them appear that they're fairly polarized. And then we do have some streaming over here. So how would you guys handle this? Atypia or no atypia? Or immunos? Immunos, okay. So I don't have immunos for this one. But this one, so are we okay with a papillary lesion? Yes, okay. So papillary lesion for sure. And again, this is your clue that we're dealing with some sort of, that there might be a papillary lesion associated with it, and that this stuff here is probably papilloma. So I'm okay with this being a sclerotic intraductal papilloma with maybe some usual duct hyperplasia. In this setting where there is, maybe some suggestion of columnar cell changes, I think that can be a little bit tricky with ER. But certainly if you were to do ER, the other areas where the cells lack that kind of columnar morphology, you would see a heterogeneous ER expression and patchy mosaic CK5-6 expression. But you have to be careful with the more columnar appearing stuff and not overcalling ER positivity in a columnar cell area as atypia, because columnar cell lesions at baseline can demonstrate ER labeling. So be careful in that setting.